Hello, I'm Omar Abdelmaguid, a graduate student in the Health Informatics program at George Mason University. This presentation was prepared for HS 725 Statistical Process Control in Healthcare, and it looks at how Sentara Northern Virginia Medical Center performs on acute myocardial infarction care compared to its direct competitors. Using data from Centers for Medicare and Medicaid Services Hospital Compare, I'll walk through 5 quality measures, each with its own control chart, and use those charts to see whether Centara's performance falls inside or outside the range we'd expect based on its peer hospitals. Before getting into the charts themselves, I'll cover where the data comes from and a few limitations worth keeping in mind along the way. All the data in this analysis comes from CMS Hospital Compare, covering reporting years 2014 through 2024. I selected 5 measures that together build a cohesive picture for a patient trying to decide where to go for acute myocardial infarction or heart attack care. MORT 30 AMI is a 30-day risk standardized mortality rate following acute myocardial infarction. It is also called by its abbreviation AMI. READM 30 AMI is a 30-day risk standardized readmission rate following AMI. EDAC 30 AMI is a 30-day access days in acute care following AMI. REHOP 18B is the median time from emergency department arrival to departure for discharged patients. And finally, HRECMND-DY is a percentage of patients who said they would definitely recommend a hospital. Together, these 5 cover survival, recovery, complications, wait times, and overall satisfaction, the full arc of what a patient would want to know before choosing where to go. Not every hospital competitor reported each of the 5 measures every year. As a result, the peer group used to build the control limit shifts slightly from year to year. A normal feature of working with public CMS data, but worth noting since it means the benchmark isn't built from a perfectly identical set of hospitals every year. This limitation also shows up across measures, not just hospitals. 4 of our 5 measures, MORT 30 AMI, READM 30 AMI, REHOP 18B, and HRECMND-DY go back to 2014, but CMS didn't begin publicly reporting EDAC 30 AMI until 2016, so that chart has too few years of history than the rest. CMS Hospital Compare publishes the final calculated measure for each hospital, such as a risk standardized rate, a median, or a percentage, but not the patient level records used to produce it. I can see the score, but not the underlying data behind it. Things like age distribution, comorbidity risk, or sample characteristics of the patients who factored into that number. Demographics are one example of what's hidden, but the broader point is that every score in this analysis is a black box output. I'm working with the result, not the source of the data behind it. 3 of our 5 measures, MORT 30 AMI, READM 30 AMI, and EDAC 30 AMI, are all risk standardized by CMS, meaning they're statistically adjusted for each hospital's patient case mix before they're published. So differences between hospitals are meant to reflect quality of care rather than who happened to walk through the door. REHOP 18B and HRECMND-DY are not adjusted this way. OP18B is a raw median ED time, and HRECMND-DY is a raw survey percentage. That means for those 2 measures, some of the variation we're seeing could reflect differences in patient volume or case complexity rather than pure performance, so they should be interpreted a little more cautiously than the 3 risk standardized measures. This analysis used 5 quality measures in 8 competitor hospitals, a focus set chosen to build a cohesive picture for a patient considering acute myocardial infarction care, but a small sample in both directions. CMS Hospital Compare publishes dozens of quality measures beyond the 5 used here, so this captures only a slice of hospital performance relevant to heart attack patients, not the full picture. And with only 8 hospitals feeding the peer group, one unusually strong or weak performer among them can meaningfully shift the control limits Sentara is being measured against. A larger competitor set would produce a more stable benchmark. Unlike the risk standardized measures, OP18B isn't about diagnosis coding. It's a raw median measured in minutes, so it's sensitive to exactly when staff document patients' arrival and departure. Hospitals can defer in how that moment gets captured. An automatic badge scan versus a manually entered triage time, or a departure logged at discharge order versus when the patient physically leaves. Small inconsistencies in that timestamp documentation can shift the reported median by several minutes without reflecting any real difference in how efficient the ED is actually running. 2020 sits in the middle of every chart in this analysis, and it wasn't a typical year for hospital operations anywhere. Elective procedures were delayed, visitation was restricted, and staffing was strained, and patients were often reluctant to seek care at all of which can shift volumes and outcomes independent of a hospital's actual quality of care. We have direct evidence of this in our own data. HREC MND DY survey volumes dropped by roughly half in 2020 compared to a typical year. It's reasonable to treat 2020 as a documented disruption period across all five measures, not just the one where we can see it directly. So any unusual point that year should be read with that context in mind rather than as a straightforward quality signal. Control limits are statistical boundaries, not certainties. Even when a hospital is performing exactly as expected, natural random variation means a data point can occasionally fall outside the limits without anything actually changing. So a point outside the limits should be read as a signal worth investigating, not automatic proof that performance shifted. It's a starting point for a closer look, not a final verdict on its own. Sentara's Northern Virginia Medical Center's competitor set includes 8 hospitals that serve overlapping patient populations across Northern Virginia and the District of Columbia. 4 are Nova hospitals: Fairfax, Mount Vernon, Alexandria, and Fair Oaks, which reflects how much of this specific market Inova covers. The remaining 4 are Virginia Hospital Center, MedStar Georgetown University Hospital, Novant Prince William Medical Center, and Stafford Hospital. These were selected by geographic proximity. A patient in Northern Virginia deciding where to go for AMI care would realistically be weighing Sentara against these same nearby hospitals, not options across the state or country. This chart tracks Sentara Northern Virginia's AMI mortality rate year by year from 2014 through 2024 against the range we'd expect based on its competitor hospitals. The green dashed line is the peer group's average. The red lines mark the upper and lower boundaries of that expected range. Any observation that falls between those two lines is considered normal expected performance relative to competitors. The circled points are years that fall outside that range. 2024 through 2026 all sit above the upper line, meaning Sentara's mortality rate was notably higher than its peers in those years. Performance then moves back into expected range from 2017 through 2020, with 2019 actually dipping below the lower line. A year mortality was meaningfully better than the peer group. But 2021 through 2023 all are all above the upper line again, 3 years in a row before 2024 comes back within range. Overall, Sentara has spent more years above the expected range than inside or below it, 6 of 11. 2024 is a step in the right direction, but the broader 11-year picture is one of inconsistent performance relative to competitors. This chart tracks Sentara Northern Virginia's 30-day readmission rate for AMI patients. 5 years fall outside that range, all on the high side from 2014 through 2017 and 2019. In each of those years, Sentara's readmission rate ran higher than its peer group's typical range. From 2020 onward, performance moves inside the expected range and stays there through 2024, which is the lowest value in the entire 11-year series. Overall, readmissions were a consistent problem in the first half of the study period, but the back half shows a sustained move towards better performance, with Sentara's most recent years both inside the range and trending downward. This chart tracks Sentara Northern Virginia's excess days in acute care within 30 days of an AMI. This measure works a little differently from the first two. It can go in a negative, since it's measuring the difference between predicted and expected acute care days rather than a rate. A negative value means Sentara had fewer acute care days than expected, which is a good outcome. 3 years fall outside the expected range, all above the upper line: 2016, 2017, and 2022. In each of those years, Sentara had a meaningfully more excess acute care days than its peer group's typical range. 2020 looks dramatic on the chart, dropping to about negative 19 days, but it's actually within the expected range once you account for how much this measure naturally varies year to year. Overall, this measure shows an inconsistent pattern rather than a clear trend in either direction. 2 years of notably worse than expected performance early on, a dip to a strong performance in 2020, another above range year in 2022, and a return to a favorable performance by 2024. This chart tracks Sentara, Northern Virginia's median emergency department time, from arrival to departure for discharged patients. This measure is in minutes, and unlike the first three charts, it isn't risk adjusted. It's a raw median. 7 years fall outside the expected range. 2015 sits above the upper line, meaning patients waited longer than the peer group's typical range that year. Sentara then showed 4 consecutive years below the lower line, from 2016 through 2019, showing ED times meaningfully faster than its competitors. 2020 moves back into the expected range, but 2021 and 2022 jump above the upper line again, both well above it, before 2023 and 2024 return to the expected range. Overall, this measure shows the widest swing of any chart so far, moving between notably faster and notably slower than the peer group rather than holding a steady position. The two most recent flagged years, 2021-2022, stand out as the longest wait times in the series, though the most recent 2 years, 2023 and 2024, sit back within the expected range. This chart tracks the percentage of Sentara Northern Virginia patients who said they would definitely recommend the hospital. This measure uses a different type of control chart than the first four, since it's a survey based on percentage rather than a continuous value. The expected range is built from the number of patients surveyed each year, which is why the boundary lines shift with slightly year to year rather than staying perfectly flat. Notice the wider gap in 2020. Specifically, that's the chart correctly accounting for the survey volume dropping to roughly half its usual level that year, most likely tied to the COVID-19 pandemic. Looking at the pattern, Sentara falls below the lower boundary in every single year shown, all 11, from 2014 through 2024. It's a sustained gap that holds across the entire study period, making patient recommendation the most consistent area of underperformance relative to peers in this whole analysis. To summarize, across all 5 measures, mortality exceeded the upper control limit in 6 of the 11 years studied, 2014 through 2016 and 2021 through 2023, with 1 year, 2019, falling below the lower control limit as a favorable signal, and the remaining 4 years within the expected range. Readmissions exceeded the upper control limit 5 of the 11 years, concentrating early in the series, 2014 through 2017 and 2019. But every year since 2020 has fallen within the expected range, including 2024, the lowest value in the entire series. Excess acute days were the least directional measure. 3 years, 2016, 2017, and 2020, exceeded the upper control limit. No year fell below it, and the remaining 6 years landed within the expected range. So this measure doesn't point towards a clear improving or worsening trajectory. ED length of stay showed the widest swing of any measure, 3 years above the upper control limit, 2015, 2021, and 2022, and 4 years below it, 2016 through 2019, with no stable direction either way. Patient recommendation is the standout finding of this analysis. Sentara fell below the lower control limit in all 11 years studied, the only measure with 0 years inside or above the expected range. Taken together, Sentara showed a genuine strength in this analysis. Readmissions have been trending in the right direction. 2 measures, excess days and ED length of stay, show no consistent pattern in either direction. But 2 areas stand out as a sustained concern: a recent multi-year run of elevated mortality and a patient recommendation rate that trailed peers in every single year studied. A patient weighing Sentara against Northern Virginia competitors for AMI care should factor in both sides of that picture.